Okay, so this session is going to now focus on developing a local integrated care pathway for the prevention and management of alcohol disorders in adults. And we're delighted to have Dr. Joe McGilligan, the chair of East Surrey Clinical Commissioning Group and the co-chair of the Surrey Health and Wellbeing Board to launch the introduction. Thank you, Doctor.
Okay, thank you very much. Yes, I'm Joe McGilligan. My day job is a GP, but I'm moving more and more into the politics of health and wellbeing. Now, why do we need integrated care pathways? That was the question we were asked. And one of the things about it is we just don't do it very well. You know, we don't integrate health and social care or health and well-being in any shape or form. The thing about there's a phrase talking about alcohol. There's a phrase in Ireland that we talk about. It's a thing called about denial, and denial is not just a river in Africa. It's something that we just don't look at and don't agree with. But the thing is, this thing about the integrated care pathways we've been talking about since the first launch of the Health and Social Care Act in 1948. We didn't integrate health and social care then. It's been taken 65 years and a change in the law to get to this point, and so we've actually had to do it, and it's not been forced together. The Marmot and Wallace reports have shown that social and economic things that influence health and well-being is 40% of it is education, employment, and violent crime. 30% of it is health behaviour, so that's alcohol, smoking, and sort of exercise and things like that. And only actually 20% is access to healthcare. So majority of what we do is outside of what doctors can deliver. So actually what we should be doing is looking what can we do outside of that to do this. Now, you know, Norman said, even this morning was talking about it, but the thing about the health and wellbeing boards is that we've only have one public pound, be that health, social care or county council. It can only be spent once. So we either spend it in health, or we spend it in social care, or we spend it in education, but we can't spend it more than once unless we all dip into our pockets and pay more tax, and no one wants to do that. So it's actually how do we make the best of it. And the Health and Wellbeing Board, which I co-chair, is at the place where we have those difficult conversations in a safe place. And it is actually really difficult to actually say, well, what are we going to stop doing in order to do other things? And some of it is actually looking at how we do things differently. What we're trying to do, though, is with the Health and Wellbeing Board is actually trying to make sure everyone works together. So it's a board of commissioners, not a commissioning board. So it's really important to remember that. It isn't about everyone brings their bit to the table and not us commissioning something outside that. We have to hold each other to account to actually deliver what we should be doing. The thing about alcohol is 92% of people with alcohol harm, heavy drinkers, don't get care. So for me, the reason I got involved in this is that, hang on a minute, we're commissioning a treatment that only serves between 6 and 8% of the population that are at risk. If you had a heart problem, would you be happy with that? You'd want at least 90 or 100% of patients with heart problems to be dealt with. With alcohol problems, we push it under the table and we hide away from it. So it's really important that we start looking at it in a Health and Social Care Act, because it's got a huge impact on all facets of life in general. Now, I'm not the expert on alcohol. I'm not even an expert on commissioning, but I'm an expert on knowing when to hand over to the next speaker. Thank you very much.
He's an alcohol commissioner to talk us about his work.
Hello there. Yes. Why do we need an integrated pathway for alcohol use disorders? Well, I think most of us are probably aware in one way that as a country we have a significant problem with alcohol use. We have 24% of our population are drinking to a degree where they're putting their health and well-being or that of others at risk. So it is becoming a significant public health issue. We know, because it's very well publicised, that it is a growing problem for the NHS, both in terms of clinical management, but equally important in the current kind of financial and political context, it is placing an increasing and annually rising burden on the NHS, which I think caused the NHS Confederation to say 2 years ago that this is unsustainable. So it's something that we have to deal with, and I think we generally agree it's better that it's something we do in terms of prevention and early intervention as much as it is about treating people when they kind of get to the sharp end of the stick, as it were. Alcohol use disorders, there's a whole range of alcohol use disorders, going from people, the increasing risk drinkers who are generally quite respondent to kind of advice around their alcohol consumption, moving down to the kind of higher risk drinkers, but actually often are slightly more resistant and kind of unwilling to kind of change their kind of alcohol consumption. And then we have the dependent drinkers, and most of our dependent drinkers are the moderately dependent drinkers that can be managed within primary care, allowing the severely dependent drinkers to kind of focus with specialist alcohol services. It's important to note that within all of these, we have both those people that will comply and will engage with treatment services, but we have many, many people who won't engage, the hard to engage drinkers. And I guess if you work for a CCG or you work for a Health and Wellbeing Board, these are the biggest challenge in some ways, because these are the people that make up a high percentage of your hospital admissions, are involved with kind of children and families caseloads, and a whole range of services, including housing and criminal justice. In terms of developing an alcohol integrated care pathway for alcohol, why do we need one? We know that integrated care in terms of other models, whether it's in mental health or chronic disease management, are effective. But for alcohol use disorders, what we need to do is that we need a pathway that reflects a spectrum of care. So we need to understand, we need to focus on the prevention and the early intervention to stop people graduating to more severe forms of alcohol use, but equally we need resources all the way through the pathway that can pick up, support and respond to people who have established patterns of often very severe dependency. We need clarity of pathway in terms of people that refer into them is critical, and that's critical on lots of levels. Most significantly, because I think we're in the alcohol field, we're now convinced that if we are to have a sustainable response to alcohol, we need to engage a wider partnership framework. So more and more you will see alcohol nurses located in secondary care, in primary care, and even in mental health and offender services. So we're trying to broaden the partnership, for delivery in delivering alcohol-related harm. For many people entering the alcohol treatment system, they require an integrated and stepped response. They require a package of interventions. One of the things across the UK that we're very bad at is that we often provide people with kind of half or two-thirds of a journey. So you can get through your primary detox, you can have your counselling, maybe a bit of daycare, but when you get to the social care, which is things like residential rehabilitation, money's far more limited, so far more people have access to that intervention, which is one of the reasons I think we have higher retreatment rates, which again is very expensive. If you're any kind of local partnership, what you're doing is that you're providing people with often what is all designed to be in some ways an ineffective response. Problematic drinkers often present with multiple needs, so we have to expect that pathways run alongside each other. So many of the people that we work with have liver disease, mental health problems, other chronic disease, family problems. So pathways are important in this. So actually other agencies can integrate what they do into those pathways, provide more coordinated care. And I think more importantly in the current context, as I think one of Joe's slides made, this is the time when we need to enhance the effectiveness, because we need to make sure what little resource we have has the greatest impact. The potential benefits of an integrated pathway for alcohol use is they do ensure that balanced response to alcohol use disorders. They are about prevention, early intervention and treatment. They optimise the effectiveness, as we've just said, and they provide that framework that's critical for us in engaging with secondary care clinicians, children and families teams, a whole range of other health and social care services. There are a number of stages. Many of these I think most of you are familiar with, because I think they're things that you would apply in working with other integrated care pathways for other client groups and other settings. So I won't go through those in details. I think some of these things we've already picked out about definition, people referring in need definition about how you access a service, particularly service users, where you access and what it offers. Too many times our service users enter a treatment system and are very confused about what's available at the first stage, let alone what's available to them in the stages after that. What I'm now going to do is to hand over to Charles Randall. What we've been working on in partnership with Wellbeing is a tool, an interactive tool which enables you to, right from the very scratch, to design an integrated care pathway. And Charles is going to come up now and... Sorry? Oh. Sorry, I'll let you do it. That was the second.
Sorry, I'm going to just show you through this toolkit that we've been putting together for an integrated care pathway for alcohol to help developing an integrated care pathway. And unfortunately, I'm going to have to look down this way because I'm doing it all on the computer. So the pathway, you enter into this pathway tool. This pathway tool is in a interactive PDF at the moment, but it will be put onto a web platform in the near future, but is available now if you'd like to, if you'd like a copy of it. It starts off with an introduction about what the pathway is, and explains all the people who are involved in developing the pathway. And we had a whole range of people developing the pathway, from the Chief Exec of Alcohol Concern, public health consultants, GP commissioners, and people from the National Institute of Health Research. So that explains how to use the document. And what we did in the process, we developed a number of template pathways, which is seen as good practice pathways. They're generic, but they can be adapted locally to local areas. So the template pathways, we've got a pathway overview tool here. And down the side, you'll see there's various icons. For each icon, these icons can be clicked on. You can go through to a whole level of additional information, various tools that are available in the tool. Evidence. Governance was an area that we saw was a big problem with ICPs, because quite often it's the governance arrangements that mean the ICP falls down. Key performance indicators, and some further information around the glossary. So this is the overall view of the pathway, which is risk stratified across identifying need, prevention, screening, diagnosis. The pathway is just written for alcohol, not for comorbidities, but comorbidities are referred to. And this pathway is for England only, though we are looking at developing a tool for Scotland, the devolved nations as well. Under each of these pathways, you can click on expand and it takes you to a wider pathway. So if I click on expand there, we go to the next pathway down. So this is the first leg in the pathway for an integrated care pathway for alcohol. And this is around need assessment, prioritisation and planning. And here you can see we've looked at the key players down the side, so obviously the patient, local authorities, public health, criminal justice, other key stakeholders, and people and places. And then there's a lot of information about the joint strategic needs assessment, and, for example, identifying needs. So for each of these icons, you can just click on the icon and it takes you through to some further information. And with each of the pieces of the further information, there's a range of web links that go with those. We've got 4 levels of pathway. The second level is around screening. Third level is around diagnosis and risk stratification. So here you can see the risk stratification. And that gives the guidelines of where people should be treated. And then the final pathway is around treatment. And here again, there are a number of icons, for example. So if you click on this icon, it gives some evidence around the NICE quality standards. If you click on this icon, it gives some more evidence about non-medical prescribing, etc. The next, just to give you more detail, so behind that, we've got a whole load of tools within this tool around how to develop your local ICP. So there's a guide to development process. So within that, there's a step-by-step guide on how to develop an ICP for alcohol. And that goes from step 1 through to 7. So, and then under that, we've also got a gap analysis. And the gap analysis has a number of key lines of inquiry within it, which cover areas such as strategy, financial management, performance and value for money. Then there's some other tools around that sort of leads you to develop an action plan for setting up a local stakeholder meeting. So there's a tool around setting up a local stakeholder meeting. Obviously, users are very important in the process, so there's a user survey which has been developed by, we had a user on the advice board, and then there's an action planning process. And then we've also put together a tool which is around pathway cost calculators to support understanding the cost for alcohol in the local area. And that again has a step-by-step guide of how to look at costs. It gives literature search on public health resources, so it looks into social marketing and public health resources that you can refer to. It refers you to various other tools that are available to look at costings for alcohol, such as the Ready Reckoner from the Alcohol Learning Centre, which is now with Public Health England, the CG115, the NICE information, and there is another tool available from Lumbec called an alcohol impact model. It also then links you into other key strategies, so if you're writing a business case about your local ICP, which strategies those link with. And then we've also costed up some pathways as examples, and these have been costed using the NICE example, NICE CCG 115, and also the Kent costs for social and healthcare. And then finally, we've got an audit tool for auditing the impact of the of implementing the ICP, and that again runs you through a range of questions around implementing the ICP, how that's worked, and that draws not only on the other information within the ICP, but also on the NICE audit tools as well. And then if you click on these icons, you can look at all the information separately, for example, so that all the information separately within that icon. And if you go through, for example, on KPIs, there's a number of KPIs that have been agreed by the group there that would be useful for local commissioners. Then there's a detailed ICP here that takes you from the very beginning of the process right through to the end, which is the total overview. And then finally, there's a glossary of terms within the tool. If you'd like to get a copy of the tool, you can get free access to it from Lumbec, and if you come to Lumbec's stand, which is M30, they'll give you a password.
I'm going to finish with a...
Sorry, I just want to run very briefly through a case study just to give you an idea of one example of how we started to redesign part of a care pathway in Wandsworth. I'll just skip through these. I won't take it, I'll go through this. One of our problems was that, like lots of areas, we had a very small community alcohol team and everybody was being referred to the community alcohol team. Very few people wanted to go to the community alcohol team, and many of them shouldn't have been there. So what we did, and a lot of people were being treated in primary care, and by the admission of the GPs that we spoke to, not terribly effectively because they don't have access to all the resources you need for it to be effective. So we spoke to GPs, and I think we found that there was a common understanding between GPs and patients that treatment in primary care as it wasn't very effective, so clearly taking up a lot of GP time with very poor outcomes. Many GPs said they didn't really want to treat alcohol in that sense. They did so because there were long waits to the community alcohol team, and there were long waits to the community alcohol team because all the moderately dependent people who shouldn't have been at the community alcohol team were going to the community alcohol team. So it was a kind of vicious circle. Long waits, as I say, for the community alcohol team. And what people wanted was quicker access and more choice. Not everybody wanted to see their own GP, but didn't also want to go to an integrated kind of drug and alcohol service. So what we did was that we commissioned a model, a GP-led model, for treating mild to moderately dependent drinkers, supported a GP, a part-time GP, 2 sessions a week, supported by a nurse prescriber. It's self-referral, or we get referrals now from a whole range of agencies, whether it's adult social services, mental health, criminal justice, secondary care. It offers planned withdrawal, daily attendance. It's a very structured program based on a contract between the patient and the GP around complying with a wider treatment plan which we resource by making sure there's counselling and group support within the service and the practice. And critically, which wasn't happening as well in primary care, relapse prescribing was commenced and then handed over to the patient's own GP. And just very briefly, some of the outcomes of this. The single biggest thing was that in that one action, which wasn't hugely expensive to commission, we reduced the waiting times for a specialist service by 40%. So many of those complex people who weren't treated in primary care because they were too severe and couldn't get to the community alcohol team, and then ended up primarily being treated in secondary healthcare settings, were now able to access the community alcohol team. It increased choice with GPs and patients. It's very popular. It creates an additional 150 to 200 places in each of our 3 clinics now each year, which is a significant increase in treatment capacity. All GPs now refer all dependent drinkers through Fresh Start, where they're screened and either treated in Fresh Start or referred on rapidly to the community alcohol team. But more importantly, I think it's the outcomes. We've got really positive outcomes in terms of people sustaining their treatment gains, whether that was a reduction in drinking or whether that was actually abstinence at 3 months and 6 months, and real improvements in people's recorded measured mental health and physical health. So it's a really positive model. And as just to finish, as Charles says, that you can visit the Lumbeck tool, which I'd encourage you to do because it is a very comprehensive, very accessible, very useful tool if you're beginning to think about how you put together your integrated care pathway in your area in a way that you can manage it within existing resources. Thank you very much.